Good afternoon, and welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stein. I'm a family physician here in Vincennes, Indiana. Joining me, as always, Adam Thacker, who's our Chief Operating Officer, also stand-in pharmacist for us today as we get into the difficult questions. We'll be going over State of the Union as far as COVID is concerned in our current community. We'll talk a little bit about what our current numbers are, and then we've had a number of people that have been asking us to predict the future, so we will cautiously dance around that a little bit today also. Leading off with, we always talk about what numbers are in the community, around 6,200 cases since the beginning, but really what it always comes back to is what the positivity rates are. Those positivity rates looking over the course since we spoke last, around 15.5% for the all individuals and about 41% for unique individuals. So the question just becomes, as you and I spoke about last week, it seemed like things were getting a little bit better. Are things getting worse, or are we seeing just a variance in data, or what are we looking at right now?
Yeah, and I think one thing that we always have to balance is reporting of information and boots on the ground, what's happening, what's the reality of the situation from a medical standpoint, and there's going to be volatility. When we're looking at the numbers with the scrutiny that we do on a week-by-week basis, you're going to see some of that volatility. So some of that is catching up in reporting and getting those numbers in, and there's also been a pickup in cases. So we haven't went to the effect of tripling number of cases, but we have seen some increase in cases and a catch up from a lagging reporting, as the state's been pretty inundated with numbers coming in to report on the ISDH website. What I always like to look at when we do see those spikes is what are we seeing in our clinics, what are we seeing in the hospital. And our hospital inpatient census for COVID is actually down. We have 11 patients in the hospital, 2 on ventilators, so 2 of the highest acuity. But we've been in the 20s during this surge, and go back just a few months ago, and we were running 30s and 40s. So certainly in a place from a number of patients requiring a hospitalization that we're comfortable with that, because end of the day, that's what we want to see is where are patients that are requiring hospitalization and medical attention.
And just as Adam is saying, the other thing that we see on the clinical side is what's happening in the ambulatory world. And we haven't seen as many patients coming in the ambulatory setting. Volumes at our community care continue to be high, but the number of positivities that are coming out of that are less. And then the other thing that we go back to is what are we doing as far as utilization of monoclonal antibody? As recently as 3 or 4 weeks ago, we were doing as many as we could in any individual day, and that was with both injections and then following up with infusions. Dr. Mahan and I, who are somewhat of the gatekeepers for that, have seen a decrease in the volume over the course of the past week or so. Good news is the availability of that medicine is still very good. We had a little bit of a lag as far as supply a couple weeks ago, but that has remained strong, and currently looking good as far as those numbers. So again, we go back to people and say it's important to make sure that they get identified early as far as when they turn positive, when their symptoms develop, and then getting administration of that medication.
Yeah, it's we've talked about it for almost a year now, as we're coming up on November when it was released a year ago, and it's been just a phenomenal tool in aiding in treating high-risk patients that in all likelihood, upwards of 50% of those individuals are at pretty high risk for being hospitalized, severe illness, and we've seen greater than 95% of the patients that have received treatment have been able to stay out of the hospital. A varying degree of symptoms from get monoclonal antibody and feel pretty good the next day and start to return to normal, to some are sick for a week plus, but not anything that's leading all the way to hospitalization. So thankfully our pharmacy team, our nursing team, you and Dr. Mahan as gatekeepers have worked really well in identifying patients, getting patients scheduled, getting them in timely. Because as we've talked about so many times, positive test, identify high risk, at risk individuals, and then get them in quick before really the virus starts to build a viral load and take over the immune system to some degree. And we've been able to get patients in, some even same day, but most are within 24, 48 hours later are getting treatment and really turning around.
Yeah, one thing I'd like to talk a little bit about today, which we've touched on in the past, one of viewers from Lakeland, Florida that I spoke with over the weekend had a question for me about why we talk over and over and over about this being a disease of the unvaccinated. And we've touched on that a bit in the past, but her specific question was, can we comment a little bit on what population is getting ill? Meaning, are these just perfectly healthy people walking in off the street that are contracting COVID and becoming terribly ill? And the answer to that is generally no. The population that we see that are affected the most by this certainly are the unvaccinated. But when we stratify them into age range, those individuals who are older have much higher risks and tend to get sicker. The other thing are those comorbid conditions that we talk about. And interestingly, we see patients all across the spectrum because diseases don't happen to be just in the elderly. We see patients that are in their 30s and 20s that have diabetes and hypertension, obesity, and it is affecting those individuals just as severely, not because of their age, but because of their disease process. And so when we look at that, it's important to realize that those individuals who might think, well, I'm 35, I'm 40, if I get COVID, I'm going to be fine, need to also back that up and look at, well, what disease processes do we have? So that's a really important factor in keeping this in mind, that yes, the patients like Adam's talking about that are our inpatients in the hospital predominantly are unvaccinated. And when we look at across the state and across the nation, that tends to be the case. But that population is not just the healthiest of all the patients. It's patients who are more advanced in age, who have obesity, who have hypertension, diabetes, and unfortunately those individuals might think, well, because of my young age, I'm fine, I'm protected, so forth, but really what they need to look at is what their comorbid conditions are.
Yeah, and a lot of it comes down to, we're talking about a viral infection and your immune system's ability to fight off the virus from mounting a viral load and really taking over. And so the number one risk factor, as it is with most of these, is age. Because as we get older, our immune system tends to weaken. So as we're, and going all the way back to where this started, we started to hear of cases out on the West Coast, and it was nursing homes that really started the whole just really broad awareness of this is a problem. And then as things moved across, that was our number one priority early on, was protecting the most vulnerable, which at that time was our elderly population, nursing home population, elderly community members. And then you start to look at those disease states you mentioned, health conditions, diabetes, congestive heart failure. Obesity is probably number 2 to age, but it tends to lend itself to all the other ones that we're talking about with cardiac and pulmonary issues. But again, when you boil it all down to, it's the immune system's ability to fight off the virus. Age is first, and then as you have those other comorbid conditions that we call them in the healthcare field, it weakens your immune system. And that is what really lends itself to risk of hospitalization, and then ultimately that creates a risk for death.
Yeah, and the other part of her question also was for an individual such as herself in her 80s, who's vaccinated, otherwise relatively healthy, should she be overly fearful? And the answer is no. She's doing all the things that she should. And so individuals who have taken those precautions, have practiced good hygiene measures, appropriate masking, so forth, and gotten their vaccinations, they're doing everything that we've asked them to do. So we would hope that they would continue to feel good about that.
So we go back to kind of the root of her question, why vaccinated, unvaccinated, and when we're talking about the at-risk populations, and to be clear, there have been many healthy individuals that have ended up in the hospital or had very significant illness, and that's just a much smaller population, and we tend to focus on where the biggest risk is. But all the way back to just the very beginning basics of why vaccination is because the vaccine teaches our immune system to respond quicker and recognize, okay, that's the COVID virus, I need to attack that and get it out of my body, whereas otherwise we don't recognize that. So somebody with a weakened immune system, age, comorbid conditions, whatever the case may be, they need that kickstart, that quick, hey, I recognize this, my body's going to fight it, to keep from becoming severely ill. And that's why today we sit here saying that 90% of the patients since the rollout of vaccine, 90% of our patients have been unvaccinated. We kind of root ourselves in science and data, and the data doesn't lie that we're seeing 90% here, and it's 90+% across the nation are unvaccinated. The severe illness, the deaths are predominantly shifted to unvaccinated. Now, very transparent, there are breakthrough infections. There have been vaccinated individuals that their immune system wasn't able to fight off the virus, and there have been death of vaccinated individuals, but in a much smaller portion than what we have seen of the unvaccinated. So that's why you've heard so many people say this is now a pandemic of unvaccinated, or this is a disease of unvaccinated, is because we have this medical tool that can help us to really prevent severe illness, hospitalization, death. And when we're seeing that it's not being taken up at the rates that really allow it to do that, we end up with hospitals that are overwhelmed across the nation, and they're reporting predominantly as unvaccinated individuals in their hospital.
Yeah, and we would certainly also encourage people to identify those risks early and act early. One of the unfortunate things that we see somewhat feel very powerless for, is when individuals contract the illness and say, well, I think I'm going to do fine with this, and they sort of wait it out. It becomes more of an issue because, just as you said, when their immune system becomes overwhelmed and then they come in to take action, get diagnosed, ask about treatment options, so forth, they're kind of outside of that window. We had a relatively healthy individual this past week in his 40s who had waited 14 plus days and was very sick, and then decided to seek treatment. And so that individual had risk factors, including hypertension and obesity, two of the primary things that we see that people frequently underestimate as potential comorbid conditions. But it's important to recognize that early and take action. The monoclonal antibody, as you mentioned, really takes action and does its best work in those first few days of illness. So we ask people, preferably 7 days less, at the most 10 days or less from symptom onset, to get to see a provider, get diagnosed, and then find out if that treatment is an option for you, because that early action potentially saves you.
And the management of those conditions is not as big a factor as some might think, because I've had some ask the question, well, I'm a diabetic, but manage my diabetes very closely, my blood sugars are in line, or I'm hypertensive, meaning I have high blood pressure, but I take my medication every day as I should, and I keep my blood pressure where my physician says that I should. But at the end of the day, clinically, you still have high blood pressure, you still have diabetes. Those disease states still weaken your immune system, even if managed to where you may not feel that on a day-to-day basis and live a active, full life. It doesn't mean that you have to be in a situation where you just feel awful. Those disease states, they still have an impact on your body. So somebody who tests positive but has done what's important and appropriate to manage their chronic conditions should still consider monoclonal antibody as a treatment.
Yeah. And going back to kind of that population, frequently those individuals are now asking us too about the booster. What should I do about booster? Every day I have individuals that are asking me, is it time to get a booster? Should I get a booster? And the most important thing is to look at, have you gotten the vaccine first? So we really want to make sure that population has gotten their first set of vaccines. And then the booster comes up basically 6 months after that initial vaccination. And the population, again, we look at as being somewhat stratified in terms of risk. So the individuals that I'm seeing in a clinical setting and saying, you really should be individuals that should go and get vaccinated and get your booster, are those individuals that have those same medical conditions, immune systems that are potentially not as good, people who take steroids for a variety of other conditions, cancer therapy patients, so forth. Those individuals and those individuals over the age of 65 plus, we're really saying, you're the folks that should go out and get boosters. What's the story on where they can get that, and what's appropriate, and what vaccines currently we have available for them?
Sure. So our Pfizer vaccine is the FDA-approved vaccine, has been approved for boosters age 65 and older, then that population really 18 to 64 based off those medical conditions, occupational risk. Can get those anywhere that you can get your first vaccine as well, which our local pharmacies around the community are providing those. Our health department, Knox County Health Department, is providing those. One thing that we've been really fortunate in Indiana and honestly across the United States is access to vaccine has not been an issue. We have ample access, same day access, next day access at no cost. That's still kind of it still is a federally funded approach that if you don't have insurance, ability to pay, still get registered, get vaccinated, you will not be charged for that. And then from just an update on the other boosters, because we get the question, well, I already received my vaccination Moderna, or I already received my vaccination from Johnson & Johnson. Tomorrow, the FDA is reviewing, the advisory panel is reviewing Moderna for booster approval under the same populations at risk or populations identified, I will say, as Pfizer, that 18 to 64 occupational or health conditions, and then over 65. So Moderna is tomorrow, and then on Friday is Johnson & Johnson. So those will be reviewed by FDA. That doesn't mean on Friday they're both approved. The next step then after that is it goes to the CDC for an advisory committee on immunization practice. They will look at that. I really don't see anything out there that suggests that won't be approved. There has been some Moderna data review by the FDA that has stated that the gap of improvement in protection from initial vaccination series to booster was smaller than what they anticipated, but that's not a bad thing. That's because the initial vaccination with Moderna has proven to hold its vaccination efficacy at a higher percent longer. So it's not that the booster's not working, it's actually that the first two shots are working better than was anticipated. But still, data does show that the boosters do what they're supposed to do, which is boost efficacy. So by next week, we'll start to hear more detail on that. And I would think by the end of the month, we probably have approval for all three of the vaccines that are in use now in the United States for booster.
Yeah, and the patients that I've had that have already received boosters have had very few complaints as far as any symptoms, side effects from the vaccine. Most unique one, I had an individual that said for about a month afterwards their urine smelled like marshmallows. I'm not sure exactly what that's supposed to mean. Nonetheless, though, it's been extremely unlikely, so very well tolerated. The other thing that has kind of come into the news lately is the other drug possibilities that we have coming up. Molnupiravir, which is the Merck product, has come into light as being significant in reducing hospitalizations for mild to moderate by about 50%.
Right.
Contrast this with what you were just quoting in terms of monoclonal antibody, which is fantastic. This is still pretty good. And the exciting thing about it is that instead of being either an injection like the monoclonal antibody or an infusion, it's a pill. And while the statistics are not quite as good on it in preventing hospitalization, the access to it would be the big game changer, meaning that people would be able to access much more quickly, much more easily. And although we get most of our patients in within a day or so to get their antibody infusion, this being rolled out and potentially becoming approved will be a game changer in early intervention in the disease process.
Yeah, and you draw some comparisons to influenza and Tamiflu many years ago, and starting to have that early identification of symptom onset, having an oral treatment that you can pick up at the pharmacy for those that when we talk about monoclonal antibody, for those that don't appreciate the needle, the infusion, sure. This becomes certainly a valuable effort in addressing hospitalization, risk of severe illness. We always kind of come back to, though, that still requires getting the virus, getting sick, having symptoms to a point that you're seeing a physician, nurse practitioner, whomever your provider is, and making that treatment. So not a replacement from a vaccination status, but seeing antivirals that are coming on board from an oral standpoint is really good. So Merck has this product. I know Pfizer actually has one that they are studying as well. The timing of that becomes the question. Merck has submitted to the FDA for authorization. So we're looking at 6-8 weeks maybe that they will have that reviewed and have some input to that. It's all the way through phase 3 trials and has been very promising. So again, just another tool in the tool belt, if you will, of how we kind of address COVID moving forward.
And of course the question will come up, where did these drugs come from? Where have they been sitting, where have they been waiting? And in fact, a lot of the research that has been done on a lot of these antivirals goes back to SARS and MERS and some of the other equine viruses that have been around for a very long time. And because a lot of those other epidemics and pandemics kind of burned out, the companies shelved this research and were waiting to see if they would need it again. And that's really where that has come back out of. The process by which this works compared with the remdesivir is a little bit different, and so the hope is that having multiple agents for treatment with different modalities is always appealing to us. This one uses something called lethal mutagenesis, which sounds pretty fantastic, right. But basically just breaks that genetic code so the virus burns itself out. So it's sort of exciting to think that that's on the horizon. It's already being used and showing that 50% reduction in hospitalizations with mild to moderate COVID. So again, work is being done out there, research is being done. We're kind of along for the ride, trying to endorse the most effective things that we can along the way. But again, going back to making sure that we use the usual precautions. Now, we've had a number of people request that we predict the future, and so we'll go into the predict the future segment here, which we dance lightly around, as far as what our upcoming viral season is going to be like. Obviously, childhood viruses start to erupt around the time of onset of school. We saw that. We're seeing viral gastroenteritis going around right now. Flu, there have been just a handful of cases. So everybody wants to know what's the winter going to bring. So I'm throwing it to you, pharmacist.
Is that 8-ball back here? So yeah, I mean, there's a lot of factors that play into it. I think if we look back at last year, we're starting to see an uptick in viral illnesses, the seasonality changing, moving things more indoors, and I would expect over the next couple months, I mean, we're going to see a pickup in cases. And what it really comes down to is how diligent are we as a community. How are we going to follow hand hygiene, distancing, monitoring our own symptoms? I think one of the things that's in place now and probably forever that wasn't 2 years ago is that general awareness of monitoring symptoms. If I don't feel well, have a runny nose, headache, sore throat, don't go to work and tough it out, but because we could be contagious.
Yep.
And the awareness of that, I hope, is going to plateau some of those from really becoming a surge that overwhelms hospitals or becomes something that's shutting down the community. But I certainly think as we move into this season, we are going to see a increase in cases, COVID, flu, RSV, as you mentioned, across the board. But there's not really anything that lends itself to believe that it's going to move all the way to the point of early pandemic where we are shutting down the world, so to speak. And the reason for that is what we've spent most of the time today talking about. We have treatment modalities now that we didn't have. We have preventative medicine and a vaccine. We have an antibody infusion that is 95% plus effective in keeping patients out of the hospital. We have new oral antiviral medications coming on board that at early diagnosis can help to treat individuals. Whether that will be here for this winter season, probably unlikely. But nonetheless, we have those treatments. We've got Knox County at 48.6% of the community is vaccinated. You start to look at where we were in the low 40s to where we've gone to. We're kind of catching up to where Indiana is as a baseline. And, I'm saying all this while some people are probably thinking, well, I saw Indiana was one of the 25 states that's declining. Well, yes, we have. But, I mean, we expect going into the winter that is not going to be the case. We're going to continue to pick up. But where we've seen the decline is where we have seen vaccination rates go up. One thing that's held true since December of 2020 is vaccination rates go up, infection rates go down, and we just need to continue to push that, get that message out there.
So that didn't sound like doom and gloom, because
No.
a lot of people are predicting doom and gloom as we go in the winter months. And although we see an increase in all viral infections, that's something that we're used to dealing with as we go into the winter months. So
I think we're learning how to live with this to a degree to where it's certainly not an ignore it and just take your risk type of thing, but we're learning how to live with it to a much higher degree. And it's about those precautions. I mean, wearing a mask is not even an inconvenience anymore. It's just something we do. Hand hygiene and awareness of, sharing of utensils and that type of thing is just something that we're much more aware of than maybe we used to be. And those are all infection prevention measures that were always the right thing. We just were really naive to that.
And really, our school systems have been a model for kind of a hybrid system as to where they are right now. And I applaud them and all their administrators and teachers and parents who have done such a good job with that over the course of the last few months in adapting to what I feel like is a great approach, which is common sense measures. If your kids are sick, keep them home. The other thing that I want to touch on a little bit today that we're getting a lot of questions about is asymptomatic testing and what I would call the futility of doing that. a lot of people, because of concern, are sort of jumping the gun and wanting to get tested with any degree of exposure. And although we are a long ways away from the initial contact tracing that was going on early in the pandemic, what we don't need to do is, I saw you today and you were diagnosed with COVID, and now I need to immediately go out and get tested, because that makes absolutely no sense. So in the school setting, in the workplace setting, so forth, we are absolutely not endorsing or recommending that folks go out and get asymptomatically tested. Now, if you get a few days in and you start to develop anything that you would assume would be consistent with COVID symptoms, absolutely. The reason that that is important to keep in mind is the accuracy of these tests is extremely good. However, the accuracy drops off dramatically if you have just been exposed. There is little to no utility in doing that.
Yeah, and you say accuracy, but the test is still accurate. You tested when the virus probably wasn't in the nares, in your nose. So if you go to our convenient care, some of the questions that will be asked: if you're an exposure, when were you exposed? Do you have any symptoms? If the answer to that is, I was exposed today and I don't have any symptoms, in all likelihood you're going to be told, we're not going to test you, and you need to come back in 3, 4, 5 days, or if symptoms develop, because that's when the test is going to be accurate. That's when we're going to give good information. And when we talk about transmission, that's our responsibility in the medical world, to make sure that we're performing the test at the right time to get the right result, to be able to manage accordingly to transmission. Giving somebody a negative test result on the day that they interacted with a positive individual 2 hours ago, all that does is send them back out in the community to where they potentially are developing virus and becoming contagious, and then 4 or 5 more people have been affected that didn't need to be. So we have to be cognizant of that. It's not always the most convenient thing. It's not always something we want to do, but that's how we control this to a degree where we're not at a point of shutting events down and making those decisions that impact the larger whole.
Yeah, and those individuals that are young, otherwise healthy, that don't have a lot of risk factors, perfectly reasonable for them to ride that out at home. Should they choose to be tested or not, that's fine. The testing that is available in our local retail places is the same test that we utilize, the Binax Now test, which is extremely accurate if utilized properly. We spoke a little bit last time on making sure and spooling up your YouTube video and appropriately sampling your nasopharynx. The idea is that the technique of that is extremely important in getting an accurate test result, so we want to make sure that people do that. So as we kind of move along, any other big things for us to touch on this week?
I don't believe so.
Okay. Tiffany, back with us from Bicknell.
Back from Bicknell. So I did have a question on Facebook asking to clarify, I guess, some conflicting recommendations on when you can get your flu vaccine after a COVID vaccine or booster. They have been told elsewhere that they needed to wait 3 weeks. So what's your take?
So there is no waiting period, and that's the CDC answer. That is the Pfizer FDA approved answer. The flu vaccine and the COVID vaccine can be given at the exact same time, one in each arm, and there is no waiting period. So the confusion, though, comes, as is certainly understandable. There have been, changing and evolving recommendations throughout this. So go all the way back to December of 2020, when we started giving COVID vaccine. It was just released, Moderna and Pfizer at that time, and there was a CDC recommendation to wait at least 2 weeks waiting period between COVID vaccine and any other vaccine. I didn't mention flu vaccine, it was just any other vaccine. The reason for that was all for data collection of any potential adverse reactions, to know that was COVID vaccine. It wasn't, well, in the other arm I got flu vaccine and now we don't know what caused what. It wasn't, any reaction. And as you have mentioned before, we look at the pediatric population. When their series comes up, they're getting 2-4 shots at the same time, and the immune response is just as effective. There's no cross sensitivity. They're able to handle that very well.
And then we had some questions that were submitted before we went live too. So someone was asking about if there are any theories about the spike in cases over the last week.
Well, I think there's all kinds of theories, and as Adam was alluding to earlier, some of that we know is reporting lag, just simply because of volume. We know that from more events moving indoors, that we're seeing more of that, more fall festivals, more events, sporting events, all these types of things probably play a role in this to some extent. However, really what we go back to is what are the outcomes of those cases. So it kind of speaks to the all test positive versus unique test positive. What's really the impact? And as Adam said earlier, the thing that is probably most comforting to us is we've seen a decline in hospitalized patients. We've seen a decline in the ambulatory world and administration of the monoclonal antibody. So what that means is even though there may be cases out there running around, the good news is the majority of them are not resulting in severe illness. And really that's what we care about. That's the whole purpose again behind vaccination. Early intervention with the medications we spoke about is not allowing that to progress to something that is going to have a lot of morbidity or mortality in this population. So, thankfully, when young people get this, there aren't a lot of complications. The one population that has sort of risen to the top as a little bit more of a target population is our pregnant population.
Absolutely.
And this is something that we didn't necessarily see earlier in the pandemic, but certainly over the course of the past few months, many organizations, ACOG, maternal fetal medicine organizations, the CDC has recognized the fact that we are seeing more hospitalized pregnant patients early, mid, and late pregnancy with more respiratory complications as a result of COVID. So you will see in the media, you will see in magazines, you will see in your doctor's offices more publications encouraging pregnant women to get vaccinated at any phase of pregnancy because of those risks. And then the benefit, of course, is that that also gets passed on from an antibody standpoint to the fetus and then also the baby during breastfeeding.
In that pregnant population, we didn't touch on them earlier with the at-risk, high-risk populations. And when we look at over 65 or our 18 to 64 that have chronic medical conditions, their vaccination rates have been very high. They've really stepped up because of the risk and been vaccinated. And pregnant women are in that same boat as they're at higher risk for hospitalization, severe illness, but their vaccination rates have actually went the other way. They're somewhere around 50% of what our population is. They're running in the 24, 25% range that we hear quoted, and that's scary because that's one of the high-risk groups that has not really stepped up and said, I need to get vaccinated.
Right, and I think part of it was because of initial concern.
Yeah.
And the nice thing is we have enough time under our belt now, enough vaccination experience now to say that it has been very safe, and more importantly, it's keeping some of those patients out of the hospitals, because there is nothing worse during pregnancy than to have some type of infection that puts you at risk or your fetus at risk for preterm delivery, so forth. And something that's not a popular topic within our pregnant population is that geriatric pregnancy starts at age 35. So we don't like to think about that as the age at which that's considered the diagnosis, but the risks go up at that age for a whole variety of reasons, and same thing is true for COVID. Sorry, 35-year-olds.
Another question that was asked was just asking about the morale among healthcare workers and hospital staff, being 19 months into this.
Sure.
What's it like?
Well, I think if I were to put a graph of our COVID case count and when it's down and up and down and up, that the morale kind of follows disproportionate to that, and that when COVID goes up, morale goes down. And that's just because of the fatigue, the stress, the anxiety, even more recently the PTSD based off of what they've already been through and now going through it again. Staff continue to step up all throughout this, have been recognized as heroes. Obviously were before the pandemic, but certainly many have been recognized in that regard now. But I think that there's a lot of stress in the healthcare world, and even to the point, I see some that are starting to talk about it as kind of moving past stress to trauma. So stress is something that we're stressed, but there's an end. And then when that goes away, we kind of reset to baseline. Trauma is you're probably changed forever. And so we've kind of moved into that. And there's going to be more and more coming out on just the overall impact of the pandemic on the healthcare workforce. I had a news feed that hit my inbox today, and it said there have been over 1 million healthcare workers leave healthcare in the last year across the nation. And so the impact of that and the why they're leaving is because of the stress and the impact of the pandemic. So we're doing a lot of things at the hospital to try to, appreciate our staff that are either directly taking care of patients and, wearing PPE and donning all of that to go into the room and put themselves at risk, to those that are in supply, ancillary departments that are supporting them to do so, because whether it's the nurse, the physician, pharmacist at the bedside making decisions about the patient care, or whether it is the team behind them in purchasing and environmental services and engineering that are making sure everything else runs, it really does take that fully functioning team. And there's stress at different definitions all across the organization. But the team continues to step up and every day impressed by everyone that decides to come to work and really make a difference in taking care of patients.
Yeah, and this has obviously been a difficult thing psychologically for our workforce, for the patient population, for our adolescent population. But it's important to realize that these traumas, these types of things with medicine have been around for a long time. The thing that has separated this from other things is sometimes people make choices that cause themselves to get sick, and that's very difficult for healthcare workers to deal with, is why did this happen when it didn't have to happen? We've always dealt with that, though. People who don't take care of their diabetes, people who have self-destructive behaviors, smoke cigarettes, drink too much alcohol, all of these things are processes where people have potentially made some dubious choices, but we are there to take care of those consequences and help those individuals and help them make better decisions as well. The thing that I can tell you from our population in the ambulatory world is the satisfaction of helping patients has always been there, and it will always be there. And so thankfully, we still have that as our greatest reward in taking care of patients. And we thank everybody who's been part of this system. The ancillary staff has been fantastic, because none of this can happen without them doing their jobs as well.
Okay, that's it.
Fantastic. Any other things before we sign off today? All right, very good. Well, thank you all very much for joining us. We'll be with you again in a week. Be safe.